Thank you very much. Thank you, Milena, for the introduction, and thank you again for inviting me to present at this conference. I will apologize that this presentation is slightly removed from the main core of the conference, and it's also a very general overview. But I would like to thank the previous presenter, because I think we have some points in common, and I will take many of the aspects that Anton mentioned and extend these into questions of standards and regulations around such aspects as well. And first of all, just want to mention that the use of personal protective equipment, although it has become, of course, very core during the pandemic, is normally considered one of the last resorts needed in a workplace when you have material, because there are different strategies that can be used ahead of adopting protective equipment to eliminate the product, to substitute something else for it, to use controls to isolate people, either through barriers or containment of the hazard, or using administrative systems so that people do not work for the same length of time as they might have otherwise with the hazard and so on. And the last resort, when those aspects cannot be applied, is to use personal protective equipment. And of course, respiratory protective equipment is part of that. When it came to COVID, there's a sentiment of a sort of parallel set of criteria that are undertaken to, of course, unfortunately, impossible to substitute anything for the material, but you can remove or prevent its entry through improvements in controls. Adequate ventilation, of course, as we know, is very important. And the last resort, again, is personal protective equipment, but that has come to the fore, both in workplaces and in the public domain, with the use of masks of various kinds to aid in the prevention of emission as source control, or the prevention of intake of infectious material by people. So usually in the occupational hygiene world, PPE again is the last resort, but we are finding it is, of course, one of the first things people think about because of the difficulty of addressing the other points in the short term. Just to say, there are differences also in the way that the overall respiratory protection is implemented. In general, there's a very controlled structure in workplaces, and that respirators are used as part of a major program where there may be medical surveillance, training, and regular fit testing of the equipment to make sure it is being used properly. The environment has to be assessed for the toxicity of the materials present, and there is extensive guidance on how to select respirators, use and maintain them. And so this leads to the appropriate selection of a type of respirator. And across the world now, there are domains that set standards and certification structures to ensure that respirators that are sold are meeting the highest performance standards. So there is a very good assurance that people are being provided with good protection, and there is also good checks on compliance to make sure they're using the equipment properly. So this is the situation in workplaces. One might say in healthcare it's a bit looser, because it has tended to be a problem that the biological agents have had less knowledge of their effects and less control over them in healthcare workplaces. But that is also being addressed by some of the new selection standards. When it comes to the general public, we have had sort of quite a patchy situation. We have mask mandates where people are told they need to wear or must wear masks in certain situations, or maybe they don't need to, and this may change over time and with geography. Of course, we have masks of many different kinds, homemade, some manufactured, some meeting better performance standards, some meeting lower performance standards. There are some national standards now emerging around masks for the public, and I'll get into some of those later on, just to say that is sort of playing catch up now with a long-standing situation industry. But generally where those standards exist, it is the manufacturer that certifies them rather than some independent body. And of course, wear compliance is something, it's up to the individual, and it's very inconsistent. And just to say, in this case, we have focused not only on protection of the wearer, but also the source control to control emissions of infectious material from the person wearing the equipment. When it comes to both workplace type respirators and the sorts of masks that are worn by the public, the 3 Fs have emerged as something to consider in their function. And as you see there in English, it's filtration, fit, and function. With filtration, of course, it's to do with the media that is used in the product and how well it can remove particles from the air. Excellent filtration is no use if the product doesn't fit well to the face. And so that is important as well, so the air doesn't just leak around the edge and, of course, limit the effectiveness of the equipment. And the function, perhaps often missed, but it is very important, that somebody has to be able to undertake their work or live their life while wearing a mask or respirator, and that if they remove it for reasons of comfort or to talk, they are not being protected at those times. And so the capability of the product in various circumstances around the workplace and its breathability is quite critical. And so early on, I noticed there was quite a strong emphasis on filtration, and people were comparing the filtration efficiency of different products without considering the other 2 features. And so I think now at last we are seeing there is guidance available that is being produced that is emphasizing those other parts. Just also to mention, and building on what Anton had mentioned, perhaps this is a bit more general, but just to say the general aspect of what we might call community face coverings. That's a general terminology in Europe for the use by the public. Surgical masks, as historically used in healthcare, now sometimes again used by the public, and approved respirators. They do have different capabilities, and it is the case that those homemade or even designed face coverings are not particularly good at filtering, and they do not necessarily fit very well. There are some measures that can be taken to improve fit. In the functionality, they do generally allow breathability and good communication. I've included here also splash and source control effectiveness as well. Splash against incoming fluids, and source control again as to how well in general they prevent emissions from the wearer. These are very general assessments as well. Surgical masks, they are tested, at least certain types are tested for the fluid resistance, so that's improved, though there are different levels. And the approved respirators tend to be good all around. In particular, they do need to be highly capable of filtering, because that is a key feature of their functioning. They do seal well to the face. Again, the authorities require testing for approval purposes of the fit to the range of population face sizes, and also they are fit tested prior to use or selection, and fit checked prior to use. And there are, as I mentioned, strong regulations and standards in place for them. So they offer the highest level. And we have seen some countries in Europe adopt approved respirators as the minimum needed for the general public to gain better capability and better protection. That was a broad scale, a sort of general scale. There are more detailed considerations of the effectiveness of filtration and fit from a range of different designs, again from the homemade or cloth masks through to the different designs of a respirator. Generally, ear loop respirators do not fit as well as those with headbands, and those that are designed again for use in workplaces have the highest capability for both fit and filtration. And one can go on from the typical filtering face piece type product that you see in most of the pictures here, the so-called masks, as they're generally termed, to higher levels of protection for respiratory protection. And in a previous talk, I've covered some of those as well in Web Biopatra 2 years ago and 4 years ago. And so these are some of the examples of respirators going on beyond the filtering face piece to higher levels of protection. So we have elastomeric masks, as they're called, that may fit over the nose and mouth, or eyes, nose and mouth. There are also powered air purifying respirators where a motor is used to draw air through a filter, and the blower drives it up to the head, either with loose fitting, where the air just flushes out and protection is provided by overflow, or with tight fitting, where the system provides it to a mask type thing, right up to self-contained breathing apparatus where there's a separate air supply. And these come with different features and different amounts of load needed for their implementation. The highest level of protection is the most costly. It also requires the most maintenance and so on, whereas disposable products, of course, have least maintenance and are the cheapest, but offer a lower level of protection. I'm very glad that Anton had covered a lot of this already, so I won't need to talk about this very much. Again, there are layered products in the typical mask-like filters, and a web of materials responsible. And again, I think you've seen this one before. There are the different mechanisms of filtration. I don't need to go into those now. Just to mention, though, with electret media, there are different ways that these can be caused to have enhanced charge capability. The charge separation, overall they're neutral, but there are regions of positive and negative charge, and different methods have been devised both to enhance that charge and also to ensure its stability, because this charge can decay, and earlier versions of electret media were subject to decay with environmental conditions, heat and humidity, and also radiation exposure. But new technologies over the last couple of decades have ensured that there is better stability, and even after long periods, even decades of storage, these products don't lose their filtration capability. And to say again, these mechanisms mean that the materials are not acting like strainers. There are different mechanisms, and we do find, as Anton had noted, that there is overlapping of capabilities, so that overall we get a very high level of protection across a range of particle sizes. And the effect is that with this overlapping, there's actually a minimum efficiency. That's typically in the 0.2 to 0.3 micron range. That is the size range where respirator filters are tested with different materials, but that they choose the size range for the least efficiency. And again, discussing the areas where there are infective particles and transport of materials, we are looking at extremely high efficiency levels in those ranges. Research has shown there is no difference between biological materials and inert particles. So sodium chloride can be used as a standard test agent. Bacteria or viruses don't grow legs and crawl through filters. They actually just act like inert particles and can be represented by them. There's sometimes distinction with oil-based aerosols, because that offers the chance for fibers to be coated by the oil, and so that charge we talked about that's important in capturing smaller particles can be masked. And so some standards have separate types of filter for oil-based or non-oil-based aerosols, and some test with both. And the aerosol testing, again, that's a simplification of the system that Anton showed. There's standard methods of generating aerosols, feeding to a test filter, and determining the efficiency by the upstream and downstream aerosol concentrations. Sometimes preconditioning is applied, where the filter may be subject to heat, humidity, or perhaps physical impact. Testing in this case is for approval purposes is for the monodispersed aerosol, or that most penetrating size, rather than a broad spectrum of sizes. And testing is done sometimes to determine the instantaneous efficiency, and also after loading for some time, again, to note the effect of loading of the particles onto the fibers, and if that makes a difference. And by tapping the upstream and downstream feed lines, you can determine the airflow resistance, which is, of course, as a guide to breathability. So that was the filtration. Just to mention fit, and again, in workplaces, fit testing is undertaken for selection of a respirator before it's first used, and then undertaken at regular intervals. There are two basic methods undertaken. One relying on the sensation of a sweet or bitter aerosol by the wearer. It's a qualitative test, and that is used generally for respirators at the lower end of the protection factor scale. And there's a quantitative test where an instrumental method is used to count particles or determine mass of particles. Different methods are used inside and outside the respirator, and so come up with actually a numerical value of the protection. And then safety factors are applied when it comes to taking a respirator into use in the workplace. And there is something called a user seal check, which is undertaken whenever the mask is donned, which is simply to try and block the airflow and blow in or out to see if any leakage can be sensed. That's something the user undertakes, but it's not a replacement for these other tests. So there are these systems in place, again, to ensure fit is addressed. Just to mention source control, it's not something that's tested in any regulatory standard at the moment, but the studies have been undertaken as here, showing the effectiveness of different kinds of mask and respirator configuration on source control. And it can be seen in cases that sometimes the looser fitting surgical masks or cloth masks are not as effective as a well-fitting respirator in controlling the release of particles from the wearer. On the functionality side, just to summarize the factors that are useful there, obviously the health and comfort of the wearer. You see some medical workers on the side there having suffered from over tightening of their respirator, trying to get a good seal, and it's damaged their skin. So if there is discomfort, people are going to wear their products less. Communication, of course, clarity of speech and hearing. Interference of the work and dislodging by the work, and something that is tested for some industrial applications, but we really need tests for work in healthcare to determine the effectiveness of respirators in holding in place when some activities are undertaken. And then there are other factors of concern, such as the shelf life. Anton again talked about decontamination methods and the reuse of products, and also the mechanical robustness of the product, again to withstand heavy use in the workplace, and the strength of straps. On the standards, just to mention, there are standards emerging for community face coverings, and to compare the features in these, they tend to look in those standards at filtration efficiency and breathability primarily. Some address cleaning and reuse, whereas surgical masks, splash resistance, as I mentioned earlier, is measured. And for respirators, where there's a range of standards, as you see there, nearly every feature is measured. Some respirators actually measure splash resistance, but they're classified with surgical masks. But none of these are looking at source control, as mentioned, and that's something that it may be worth addressing as a research protocol to take. On efficiency, Anton again had mentioned some of the efficiency levels. We have here a comparison of European, actually Australian, being similar, and North American standards for efficiency. Each has 3 levels at different states. Differences in how they're done. Europe measures with both oil and salt aerosols, whereas in North America there are distinctions of the type of respirator according to the type of aerosol it's tested with. And that airflow resistance, or the breathability factor, again, Europe scales it with the efficiency level, whereas for North America, all respirators have to meet the same criteria for inhalation and exhalation resistance. And so these are what is in the standards. There are some standards for surgical masks and for face masks, and they sort of sit in between Europe and North America. We've heard about exhalation valves on masks and there being an issue with the ability of such masks, filtering face pieces that have exhalation valves, to limit the spread of aerosol by the wearer. In fact, some authorities ban them, or they don't allow masks having exhalation valves. There's a study undertaken by the North American National Institute for Occupational Safety and Health in the US, which actually showed that filtering face pieces that have exhalation valves emit less than loose-fitting masks and surgical masks, which is surprising because surgical masks certainly have been accepted as suitable in hospitals for source control. So this is, I guess, a very useful piece of evidence, and some protocols have been developed for covering the exhalation valves to limit the release, and that again gives superior performance against the release of materials. A couple of examples of the community face covering standards that have come in. One is a SEN workshop agreement. It's not a full standard, but it is the basis of a number of different standards in Europe, and we're seeing about a dozen different countries in Europe having adopted a standard for community face coverings. And there's one from the US ASTM organization. These are quite different, as you can see. The efficiency range is much higher in Europe, but they are using a much larger particle size in general. It's quite indefinite about the type of aerosol that they allow, whereas the North American standard is actually using the same test method as for respirators. And again, some differences in the permitted in North America. Laundering and cleaning for reuse is defined in Europe. And again, leakage, which is a key fit issue, is not tested in the European standard, but is an optional test, and data can be provided in North America. So these are emerging standards, both in the last 2 years, around barrier face coverings. That's something we're going to be seeing more of in the future. What the uptake by the public and the manufacturing community is still not clear. I actually have been talking to some of these agencies about this, because we're looking, in fact, at developing a standard like this in Canada. And I'm trying to understand the value of doing it by the uptake. And so that's in progress. When it comes to selection, just something to mention that there are, again, clear protocols when it comes to protection against chemicals. For biological agent protection, there are no defined exposure limits for biological materials. And so there has not been extensive systematic guidance for selection. It's been more on a case-by-case basis of what you might call expert opinion. But I'll mention, and I see time is getting short, that the Canadian standard developed in about 10 years ago does have a control banding method for respirator selection for biological aerosols, and I talked about this at the previous conferences, and it's basically selecting levels of pathogen type, the generation rate, and the control levels each on a 1 to 4 scale, which then are fed through an algorithm. In fact, we have a diagrammatic wheel that then gives you an output of a respirator protection level, which corresponds to as you see, the designs of respirator that we showed in a previous slide. And it was designed around existing guidance, but building it to fill in gaps. So there is guidance available, and there's certainly, if people want to ask later, I can share more information on that. And there's a link to a viewable version of the standard. So just to say in conclusion, this is a study simply based on that has been undertaken with examining the benefit of wearing a face covering or respirator on the prevention of release and the protection of the wearer. You see, when we are using no face piece, the CDC guidance of 15 minutes has been applied, and when it's sort of modest types of protection, we get I guess up to 4 times level improvement in the exposure time that could be considered to be acceptable without infectious dose. But when you start to use well-fitting respirators, suddenly you're looking at much longer times because you're getting much better protection, both from source control and from the protection of the wearer. So that's, I guess, guidance that it is better to use purpose-designed respirators than the looser fitting and I guess homemade type of face mask. So with that, thanks very much.
Thank you, Simon.
Although, this is the last slide. So just to say that's the conclusion that although mask wearing and respirator use is sort of now in the forefront with the pandemic, is based on well-established, long-standing techniques being well researched. So thank you.
Thank you, Simon. Thank you very much for this useful presentation for all of us to know who don't know more about respirators and masks. We don't have now time for questions,
Sorry.
but I would like to discuss with you. We can do that, for example, on Teams or however.
Okay.
You show number of dead tables here, but some useful. It will be useful to know. It is written, for example, 20 minutes, 15 minutes, but people here put
Yes.
mask and go out in restaurants or go outside and walk, and they don't use to walk 15 minutes. They walk a few hours and whatever, and standards are for 15 minutes. And so I think that general public need under such pandemic situation much more clear to know which type of mask to use, because we use that people usually use that surgical masks, and something that is very, very simple, and they expect that it's protected and it's work.
Yes.
But in fact, I think I'm not sure, knowing about such things, how much that protect them. Maybe protect others from them, but if it is not escalation, well, but how much it protect person that take mask, that is a question that people don't have still on their mind, and in some moment that that needs to come on a table. I'm happy that you show us all that examples, and also that port account instrument that is now, I know exactly, 35 years old because I did my PhD. Yes, it's appeared in 1987 for the first time. A few years later, I use it to compare sodium chloride and test of masks, and also that fitting of leakage of mask and test of fitting is something that is still not on the table, but how situation is coming to be, I think very soon that needs to be on a table. So excuse for this, my comments, and we need to go to the next presentation.
Thanks so much.
Okay.
Thank you.
Thank you.